Hey, it's nice to be here. Thank you for the invitation. I really enjoy getting out and talking to the community and to our EMS providers. Thank you for all that you do for us. You don't get thanked enough, especially when you come in the department and drop a sick kid. We just jump right to the kid, so we don't get the chance to thank you. So I want to thank you. I really appreciate what you do for us. You are hands and feet on the ground. You tell us what you see, and that really matters to us. If you don't feel that sense of appreciation, I want you to feel it right now. We really are thankful for everything that you do, and we don't get to see you guys a ton. You know, we do see Davidson County some, but not as much as we'd like necessarily. But you know, please continue to bring us business, and we are thankful for all that you do again for us. I imagine those of you in uniform are either coming or going. And for those of you who are going, I feel sorry for you having to stay awake for several hours after having been awake for what, 24? Is that y'all do 24? I lecture residents that do overnight, and so I'm kind of used to that, like the dozing off piece. So no offense taken already at the beginning. Well, I've really got two topics I want to talk to you about, and both are kind of short. One is status epilepticus. I was thinking about what kind of makes you guys nervous in kids, and so I thought, okay, a really sick kid, a critical kid, probably makes you nervous. The reason that I assume that it would make you nervous is because you really don't see it that often. I mean, probably less than 10% of your runs are pediatrics, maybe 12%. Y'all may actually know the numbers on this, and I may be wrong, but I would assume between 12 and 15% are pediatric runs, and probably less than 1% of those are true pediatric resuscitation. So I thought about that, and I thought about, okay, well, status epilepticus and status asthmaticus are two status that you deal with. And so asthma is pretty much the same between adults and pediatrics, and seizures can be too, but seizures are a little different because they're really hard to recognize. If the kid is shaking with his arms and legs in front of you, okay, that's not hard to recognize. But there are some that can be. So we're gonna talk about that. Sorry, there's me. Okay, so we're gonna first just define what status is, and then we're gonna understand its management pre-hospital. I also want you to understand what we do. So when you drop and we jump, I want you to know the things we're thinking through and what we're going through too, more or less so you can understand the thought processes that we're having, and also that you can prepare the family as you're riding in with them. Like, okay, here's what's going to happen when you get there. Pitfalls, and how do I know if they're still seizing? I think this is probably one of the more challenging things to determine, especially in a moving truck. I wanted to start with a case. It's a recent case I've had. I don't think it was Davidson County. Maybe it was, but it was 4 days ago. It was an 8-year-old. He has a history of mild cerebral palsy. He had intrauterine strip and had a cyst on his brain, and he has never had a seizure before, which honestly quite surprised us because of the large cyst in his brain. He certainly has a focus in his brain to have a seizure. He's never had one before. He had a 5-minute seizure at home, and you get the call. Do you have any questions for me? I'm Mom. Just shoot, and I'll repeat them for the people on the video. So you're coming in, okay, and you're thinking, okay, I've got an 8-year-old, no history of seizures, now seizing. I mean, what are you thinking to prepare for? He does not have a fever. Great question. No fever. He is no longer actively seizing. Nothing, because Mom doesn't have any diastat. She's never had seizures. So he's not actively seizing. So when you get there, he's laying on the bed, and he's not really responsive. 5 minutes. It lasted 5 minutes. It's self-resolved. Yeah, well, I was terrified watching it, so all I know was he came out of his room and vomited, and then fell down, and everything just started shaking. He was not. No, good question. Okay, so you guys are going at, is this really a seizure that he had? Is it a febrile seizure or meningitis? What does he look like now? What is he doing for us right now? I mean, what is his mental status at this point? So he's not responsive, but he's not seizing. His glucose is okay. His seizures resume in transport. And intranasal Versed is given at a max of 2 milligrams, and it comes 10 minutes later. His stats stay above 90% the whole time in transport. Okay, so we will get back to that. Those are some great questions about seizures and great questions you should be asking those families. Let's just quickly define, because I want you to be aware of the different definitions of seizures. So a generalized seizure, for the most part, always has, well, I won't say always, for the most part has impaired consciousness. And it's bilateral motor activity because it's bilateral hemispheres that are affected. And so that's your generalized tonic-clonic, where they're shaking arms and legs. And generally, I think those have a better prognosis than the partials. That's kind of the way I think through it. Your partial, there's two types. You can have simple partial or complex partial, and it's all in their ability to retain their consciousness. So if they're awake and having a seizure, then and it's focal, then it's simple partial. If they're awake, talking to you, and having a tonic-clonic, full extremities, all four going, it's probably pseudo-seizure. It's probably not real. Because if you have bilateral motor involvement, for the most part, you're going to have impaired consciousness. So, and we see a lot of pseudo-seizures. Oh, and then seizure just in and of itself, because if a family may want you one day to just say, what's going on? Why has this happened? As they're kind of freaking out. Like this mom, 8-year-old kid's never had a seizure before, and I would be freaking out too, by the way, it's transient. So basically the way I think of it is these neurons just go crazy. They just start firing like crazy. And the problem with that is, as a neuron is increasing its metabolic activity as a cell, it's going to need more oxygen because its metabolic demand goes up. So one thing that we don't do a very good job of is assisting those neurons while they're having this increased metabolic demand by giving them oxygen, being aggressive with fluids and whatnot. Because if we think of other cells, like these Boston Marathon runners yesterday, they certainly worked out their motor neurons. And so oxygen was important and fluids was important, but we don't think about that in terms of seizures. But these neuronal cells also need some assistance when their metabolic demand is greatly increased in a seizure. So status officially is one of two things. And honestly, this is what we see more of than this. So a seizure for more than 30 minutes, for the most part, you guys will have arrived by that point, and you will be actively trying to manage with medications, or multiple seizures without return to baseline. So they go seizure postictal, seizure postictal. And this is the one we see more often. Now, let me ask this question. Can febrile seizures be in status? Can febrile seizures be in status? I'm seeing some yeses, and I'm seeing some no's. Well, it's a bit of a trick question, because simple febrile seizures, for the most part, cannot be in status. But there's two types of febrile seizures, which we're going to talk about shortly, but complex febrile can. So, your question about fever was good. So if this kid did not have fever, but a 4-year-old with fever can unfortunately enter in status and it still be a febrile seizure. So now, why are these children having seizures? The number one reason is that they have epilepsy. And epilepsy is a seizure disorder. We don't exactly know what causes that. We think that there's something in the neurotransmitters with neuronal firing, and it discharges oddly, and we don't know why. There's lots of epilepsy syndromes, okay? And we're going to talk about one of those shortly. But in terms of epilepsy, when you see some of the first, one of the questions I really ask is, and I told you guys this was his first seizure, but that's a great question to ask right off. Is there a history of seizure? What does this seizure look like compared to the last seizure? Or is this seizure in character with his or her seizure pattern? Trauma is another one. So we see head injuries that cause seizures. And honestly, it's rare that kind of minor head injury that causes a seizure for there to be something bad, which is kind of surprising. You would think, oh my gosh, this basketball player landed on the floor, he hit his head, and he started seizing in front of the auditorium, and you guys are there working the game, and everyone's freaking out. But honestly, those kids actually do pretty well. They generally don't have many problems. Metabolic. So hypoglycemia is a very common reason for seizures from a metabolic standpoint, which is why your protocol, if you look at the protocol for pediatric seizure, like the very first thing you do, other than ABCs, is check the sugar, because that's an easy thing to fix. Now, how do y'all fix sugar in kids? I'm just curious. Okay, so you have the access to D10, and how much do you give? You just draw some up and give it? Okay, so you're going to give IV. Okay, you could use the Broslow. Now, I want to teach you guys real quick this rule of 50. I teach this to my residents too, and so we try to make things as easy to remember in pediatrics because everything is per kilo, and that's really frustrating for those of you who take care of adults and kids. So what I have is this. I have for you this called rule of 50. No, it's the rule of 50. To fix sugar in kids, and you can take this from neonates to 18. I'm not going to promise you can do this after because I don't take care of above 18-year-olds, thank goodness. But it's the rule of 50. So if you're using D10, you get 5 cc's per kilo of D10. Everything multiplies up to 50. If you're using D5, you give 10 cc's per kilo. If you're using D50, you give 1 cc per kilo, and then everything extrapolate it down. So if you don't remember anything today, remember that if I'm gonna check a sugar and it's low, I'm gonna fix it. I'm gonna use D10. I'm gonna get 5 cc's per kilo, and Broslow has it too.
That's on the second page of our super protocol for the
Oh, good. Perfect. Yeah, so rule of 50. Everything multiplies up to 50. Now, hyponatremia, hypocalcemia, hypomagnesemia, those can cause seizures too. We're thinking hyponatremia, we're not thinking the others very much. And these are intractable seizures. So this is a kid y'all are going to bring to us that's still going to be seizing. Because you're not going to fix, a hyponatremic seizure is going to seize until you fix the sodium. And that's one thing I teach my residents too. Intractable seizures, you need to start digging. Because the first thing we think through is epilepsy, hypoglycemia, infectious, and then when it doesn't fix, when we're not fixing it, then we have to start thinking of other things. Now, infectious. We just had a kid come in yesterday, or on Easter Sunday, that was seizing and unfortunately ended up being meningitis. Now, we do see that. Seizures can be the onset of meningitis, or at least demonstrating, hey, I have meningitis. And then pseudo-seizures. So pseudo-seizures are probably a big challenge for y'all as they are for us. We tend to characterize them in terms of an age group. We don't generally see pseudo-seizures before the age of 8 or 9. And what a pseudo-seizure is activity that's not coordinated. Generally, seizures are pretty rhythmic, and pseudo-seizures are less rhythmic. They have a normal EEG. So pseudo-seizure is kind of not a word we're using anymore. We're using non-epileptic activity. And I think that's more being PC than anything because it really is more psychiatric related than actual neuronal firing. And they're sometimes really challenging to tease out. But I had a kid one time shaking his arm, actually shaking both arms and screaming at me, I'm seizing, I'm seizing. Generally, again, if you're going bilateral hemispheres, if you're affecting both lobes, then you're probably not being able to tell me that you're seizing. So that's a big risk factor. If they're screaming, I'm having a seizure, I tend to think they're having a pseudo-seizure. So this is from y'all, straight from y'all's protocol from the North Carolina Office of EMS, and I don't know if y'all have any variations on the theme from Davidson County, but it's honestly a pretty easy protocol. It's ABC stabilization, check glucose, and then give midazolam. What do y'all carry? Do y'all carry Versa? Do you have both? Do y'all have intranasal capabilities? I really like intranasal, and it's quick. You're dealing with the airway. You're right there anyway, and I think it worked. The max on the protocol says 2 milligrams. Is that what y'all do? Do y'all max out at 2 milligrams? Because that's just kind of a low dose. So if you're giving this, and the next thing it says is kind of medical control, you can call us because we're fine with giving more than that. But sometimes, in a kid under probably 15, 20 kilos, that's probably going to work. But if you've got a 15-year-old that's seizing, I don't know that 2 milligrams is going to do it. And then apply oxygen. So one thing I think the protocol does not really address very well, it does say it in the stabilization, but it doesn't mandate you apply oxygen. And I would recommend that you do put all of your seizures on oxygen. Again, because we're trying to support those neuronal cells that are going into increased metabolic activity. And so I think oxygen really is important. And I think supplementing respirations is also important. And we'll talk about that in a second. Here's a big question. Are they still seizing? How many people have gotten to the ER and they say, oh, this patient, you're thinking they're not seizing. And you get there and whoever receives them is like, they're seizing. And then everybody jumps into action. That's happened. And it's a big challenge because our assessment is a little bit easier. They're laying perfectly still in the bed, and I've got 10 people, 10 eyes on them. And you're in the back of the truck, maybe by yourself, in a moving vehicle, trying to get an IV, and trying to help with the respiration. So we understand the limitations that you have. I have every resource available to me, and you are very limited because you only have 2 arms. And you only have 2 eyes. So I wanted to help you guys just kind of give you not necessarily a definition, but just some guides like, let me think through this. Are they still seizing? Is it possible? So assess their mental status. Now, their mental status may be depressed because they're post-ictal, and that's fine. That happens all the time. In a post-ictal state, they should be responsive to sternal rub, or they should be responsive to you stabbing them with an IV. They should kind of wake up from that standpoint. If they don't, I'm not saying they're not post-ictal, but that's kind of a red flag. Hey, why didn't you respond to that pretty painful stimuli? If their eyes are deviated, so we look at the eyes a lot. I mean, the eyes are window to the soul, and so we flip open those lids a lot and see what they're doing. If they're deviated to a certain side, then we tend to think that's probably a seizure. Can a post-ictal kid have deviated eyes? Yes. But we tend to think that's more a seizure, and treating that with benzos is not contraindicated. If they're post-ictal, let's say you incorrectly interpret a seizure when they're actually post-ictal, and you give them more benzos, what's going to be the problem from that? Yeah, really minimal. I mean, they might stop breathing on you, which can be a problem, but it's going to be minimal as long as you can support. Now, lip smacking, again, unresponsive to the sternal rub, and then unexplained tachycardia. This is one we see a lot. Now, extract the febrile population. Fever kids are going to be tachycardic. They're going to be tachypnic. That is explained. But if you cannot explain their tachycardia, they're laying perfectly still in your truck. A 9-year-old has a heart rate of 160. You're thinking, wait a second, something's not right here. He's not febrile. He's not in pain. He's not anxious. Why is he tachycardic? Then that could be subclinical status. So he could still be in status or still be seizing and not have any generalized activity. So that's a big one, kind of a pearl, and one we look to a lot. So the pitfalls that we see when these kids get dropped off is we're not really sure they're still seizing. The other thing is their mental status can be so depressed, both from a post-ictal standpoint and from a seizure standpoint, that they have respiratory depression and hypopnea. Probably the biggest thing I see is they're not having respiration supported en route. Now, I would advocate that if they're post-ictal, that we have them on CPAP or that we're bagging them, unless you feel that their respirations are really adequate. The problem is they just generally don't breathe that well, and they hold their sats for a while, and then they don't hold their sats anymore. Kids do a great job of compensating for a long time until they look over the cliff and then they jump. That may not be true of your adults. I just don't know if adults have quite the reserve that kids have in terms of maintaining cardiovascular tone and maintaining saturation. Granted, a kid does not have a tidal volume that an adult has, so they may not. You know, if you go to the operating room and put an adult to sleep, you have 8 minutes to intubate them, and the kid you have about 2. So I'm not necessarily talking about that kind of reserve, but their hypopnea is real, and we see that a lot. And this kid that I just told you about, that was one thing we really noticed, is that he wasn't breathing very well. His sats were 95, but if you didn't give him much longer, he was just going to drop. So we supported his respirations, and he popped right back up. The other thing, and this is that other topic I wanted to talk to you about, was airway. We may or may not get to it, but jaw thrust really matters in kids. You can really get a long way with correcting their airway and jaw thrusting, because they can easily obstruct their airway. And this is one we see a lot too, and one that catches us. So you've seen this kid seize, and it was generalized tonic-clonic. And now he's not having generalized tonic-clonic, so you assume that he's no longer seizing because you saw the seizure, and now he's not having arms and leg movement, so he must not be seizing. Well, the problem is they can jump to different types of seizures even in one single episode. So just constantly be thinking, are they tachycardic? Do they have any purposeful movement, or can they respond to me creating some noxious stimuli? And what is their breathing pattern? All right. So in our department, and this, some of you may dropped off in these rooms. This is 22 and 21. In our department, we jump to the airway right away. And for the most part, we're going to pull a bag out and start bagging these kids just in general. Because we assume that we need to support them. And if not, if they're breathing great, we'll just put them on oxygen. And then IV access if it wasn't obtained yet. And we're okay with that if it's not obtained. It is really hard to get an IV on a moving arm. And so that's why I like the intranasal route, and the rectal route's fine too. But so benzos. So for the most part, we are always going to do benzos times 2 if they're still seizing, no matter what y'all have done. Now, most docs are going to go 2 benzos and then move to anti-epileptic. But we're just going to start over and just say, okay, he got 3 en route. Now we're going to do 2 more. And so we usually jump to Ativan. That's kind of our go-to, and 0.1 mg per kg is where we're at. I didn't see that in y'all's protocol that y'all can do. It's just Versed and Diazepam, right? I think that was just the drug they chose. So the next is we are going to load with an anti-epileptic if they're still seizing. We like phenytoin, Dilantin. The problem with phenytoin is you can't load it too quickly. It has to go over 30, 40 minutes because it has cardiac toxicity if you flush it in there. So fosphenytoin's been nice because fosphenytoin is actually a prodrug to phenytoin, meaning it's pre-phenytoin. So you stick it in there, it goes to the liver, and the liver makes it phenytoin. And you can give it a lot faster. You can give it in I think 100 milligrams a minute or something. You give it really quickly. If they're under 12 months, we're going to give phenobarb. You could give phenobarb to an older person, but we generally give it to the little ones because phenobarb is very sedating. Very sedating. And if you give phenobarb, I tell my residents, if you give phenobarb, prepare to intubate because that kid is going to stop breathing on you quickly. And the other thing that I think that's really important to tell these families is when you're giving these drugs, hey, they may stop breathing. Not only are we prepared for that, but we expect it. Because families, I think, are in a major, major trauma mode. And when they see their kids stop breathing and you're jumping for stuff to support their airway, they're thinking, oh my gosh, he's going to die. He stopped breathing. But if you're telling them, hey, this medicine I'm giving him is not only going to stop the seizure, but it might make him so sleepy that he forgets to breathe. And that's the language I usually use. Make him so sleepy that he forgets to breathe. And so I'm going to help him by breathing for him. And then we get neurology. Now, there's a lot of variations on this theme. You can do lots of different loading drugs. And you know that mg per kilo thing I told you that y'all love so much about kids? The only easy one in all of pediatrics is seizure loading because it's all 20 per kilo no matter what drug you choose. So that's nice. We like that. Let's talk about febrile seizures for a second. Now, to have a febrile seizure, this seems kind of silly that you would say this, but to have a febrile seizure, you have to have a fever. Because we have gotten into this before. Well, mom felt that he was hot, and then he seized, and you got there and there's no fever. Is that a febrile seizure? Well, no, because we have to have a documented temp of above 100.3 before we'll call it a febrile seizure. So anything 38 and above is a febrile seizure. If they have a history of seizures and they're febrile, is that a febrile seizure? Probably not, because fever lowers your seizure threshold. So if you have epilepsy and you get a fever, or you're sick, or you're sleep deprived, you can seize from or you're not taking your medication, or in kids you've outgrown your dose. That happens a lot. Is the kids just grow? Imagine that. And in growing, they get heavier and heavier, and then no longer their dose is therapeutic. In teenagers, it's usually they're not taking the medicine. So the rule of 6 for febrile seizures is that falls between 6 months and 6 years. That does not mean that you cannot have a 3-month-old with a febrile seizure, but it falls out of the classification of febrile seizure. A 4-month-old with febrile seizure is meningitis until proven otherwise. But these kids, if you get a 9-month-old with a febrile seizure, we'll send them home as soon as they return to baseline. You kind of do nothing because most likely it's a virus. And roseola is a big one. Roseola causes fever for 5 days, temperature up to 104, 105. Fever goes away and a rash shows up. That's a very common cause of a febrile seizure. The other thing you know about febrile seizures, just to educate you so you can educate these families, is it's not the height of the fever. It's not that it got to 105, and you can seize at 101. It's not how high it gets, it's how fast it gets there. And that's really important to tell families because I get a lot of families that come in and say, it's just for fever. And they say, my son has a fever of 104. I'm worried that he's going to have a seizure. And so what we educate them is say, it's not how high, it's just how fast it gets there. And generally the other thing I notice is there's no history of fever prior to the seizure. The seizure is kind of it comes with that first jump in fever. So I also tell them, hey, if you've made it through day one, you're probably free and clear that you're not going to have a seizure this time. Now, simple and complex, we do them differently. It doesn't matter for y'all when you're managing these because you're still managing them as a seizure. But just so you have some understanding when they already had one and you're showing up on the scene. So less than 15 minutes, you have to be less than 15 minutes. It has to be generalized, and it can only occur once in 24 hours. Those are hard and fast rules to be a simple. Simple means you can kind of do what you want. And in fact, we pretty much ignore the fact that they had a seizure. We just pretty much ignore it. If it's a simple, we just say, oh, you've got a fever. Let's figure out why you have a fever. If it's complex, all bets are off, meaning you're in status. So a kid that's in status automatically falls into the complex category. It's focal or it recurs. It has more than one episode in 24 hours. These kids need to be evaluated much further for epilepsy, for meningitis, encephalitis, for other kind of complex problems. And so we tend to do a lot more with those than we do with those. Does anybody have any questions on febrile seizures? Something they've wondered about, something a family member's asked them? Yes, sir.
I think part of the common thing we talk about is the family really needs to very much aware of that. And they starting to ask us, what is the first thing to go to hospital? So if it's being seen, what is the typical thing? As you said, it's simple and complex. But the first thing is the 10, 15 minutes from seeing, should we edge the patient to saying, yes, we think you should go to the hospital, we're getting tired of the day. It's simple, you pretty much know it.
Mm-hmm.
So is there any kind of guidelines to travel through with that?
Yeah, that's a great question. I don't know that I want to put y'all in the position to deciding if this simple febrile seizure was not meningitis, because even simple febrile seizures could cause meningitis. So I would say in that guide, and I'm sorry for those of you watching the video, the question is, what do we tell families that have had a simple febrile seizure and they ask, do we need to go to the hospital? I mean, am I articulating your question? I think I would err on the side of recommending that they do and let us determine if it's not meningitis. The problem is they've had a real event, and yes, we do tend to ignore them. One, we kind of get lulled to sleep by febrile seizures, but there's a needle in a haystack out there somewhere. There's a kid with a febrile seizure that has meningitis, and I don't think that I want to saddle y'all with the responsibility of trying to determine if this is the needle. So I think I would err on the side of caution with seizures, and you can say, I don't know that they're going to do a lot. And if the kid's maybe back to baseline, I don't know that you need to bring them in an ambulance. You could recommend that the family go to Lexington or come to us on their own.
I didn't too much use the meningitis as a case, because that's the only thing we're just hearing. I think that's the thing. They're like, what else is there? We're not very aware of saying, well, it could be meningitis.
Right.
That way, if we have something to say, we're going to look for it.
Right. And you just say, listen, she had a fever and she's got a seizure. I mean, she looks okay right now, so it makes me think that this is not meningitis, but that's the really thing we worry about. And that's what the doctors are going to worry about when you get there of, is this or is this not meningitis? And so, I don't feel comfortable telling you this isn't meningitis. And I just don't want to saddle you with that risk, because one day in your career, there's going to be you're going to find a needle, and they're like landmines. I mean, you don't know when you're going to step on a landmine. All of a sudden you do. And I think that's a tricky situation. So I think I would err on the side of bringing those in, or letting the family bring them in, or vice versa. Great question. Are there other questions on febrile seizures? Because we see them a lot, and they scare families. They terrify them. The thing I find it's really reassuring to tell a family, like, that was really scary. I'm sorry you had to see that. And they generally are, they really respond well to that, like some empathy of like, yeah, I deal with seizures. I can't stand them. I hate when they seize. Like, it's just so terrifying to watch your child. But if it were my own child seizing, I would be a wreck. I think it really empowers them a little bit, because if it were my child seizing, I would be a wreck. So, I told you he wasn't seizing, didn't I? Did y'all remember that? Changing the case on him. Sorry about that. So that's wrong. He was not. But oh, no. This is ED arrival. When he arrived at ED, we actually determined he still was seizing because only his eyes were deviated. He was laying perfectly still, and he was heart rate of 150, 9-year-old, 8-year-old, afebrile, and his eyes were deviated. So we thought he was seizing. And then his eyes were deviated to the right, and then they went superior, and we thought, I guess he's still seizing. So we even had a hard time figuring out. So we were like, okay, benzo. We just started blasting with benzos. Gave him a phosphatidylcholine load. The other thing we noticed is that he was depressed from a respiratory standpoint. So we positioned his airway, gave him back valve mask ventilation, and that helped. And then we initiated drug therapy. It took a lot of drug therapy to get this kid to stop seizing. Again, he's got a cyst in his brain from having a stroke in utero. So I'm kind of surprised he went 8 years without having a seizure. Unfortunately, he had his first. He kind of made it this long. So, are there any kind of burning questions on seizure management, things you're wondering about?
Doctor, with respect to the case we just talked about,
once he had his first seizure, is he going to be calling out every on a regular basis? Is there any kind of time frame that the parents are going to be looking for with respect to how often his seizures or if you get a little physiology on that?
Yeah, it's a great question. I mean, you've got a cyst in there, so there's already a space-occupying lesion that lended itself to having abnormal neuronal firing because the anatomy is distorted. So the question is good. How long before he's going to have his next seizure? How do we educate the family? We don't know the answer to that. He may not ever have another seizure. He's going to go on anti-epileptics now to try to control some of that abnormal neuronal chemistry that happens right around the site of the cyst. But unfortunately, I don't know that this kid will ever be off anti-epileptics. He may be a lifelong kid with, called epilepsy. Other questions? It grows with the brain generally, but it doesn't. It really just generally goes with the brain. So I mean, they can get pretty large, but they grow with them, so they don't feel it necessarily. It's not like a big change, and they can bleed into them. And that's a big problem. But and again, I don't really see adults very much, so after they turn 18, I don't really know what happens to them.
Regarding the benzo, if you go to you at I know it's going to count you at I'm not giving you not yet.
Yeah.
I have value with that, and I have you for
I don't have a button. Right. Whatever's easy to get and use is fine. Anytime you give a benzo, think about their breathing. And that's what I tell the residents, like, benzo equals, hypopnea, so just be ready for that. But I don't care what benzo you give.
But on that topic, if you were to give this benzo and then you did high priority, is it wise to give the same thing? Or that's going to be a fact makeup is powerful.
Generally not. And you mean in terms, so the question is there a problem with giving diazepam and midazolam? And concurrently, I mean, do they interrelate? Do they potentiate each other? Do they cause toxicity when you put them together? Okay. Yeah, so great question. Can we or should we jump to a different drug if the first dose doesn't work? Generally not. I would just use what you have in your hand. And it's not that it didn't work, it's just that it wasn't enough to kind of dampen the, you think of a guitar, like all the strings kind of shaking and you're just putting a dampener on, but if that didn't work, put another dampener on to try to get it to stop. So, benzo, and if you do 4 rounds of benzos while you're coming to me, that's fine. I mean, I still want you to stop it. Every 2 minutes, you can give another benzo, just be ready to support their respirations. I mean, there's really no contraindication, just keep firing away. But no, that's I mean, I don't really switch from Ativan. I just use Ativan. I just keep giving Ativan.
Someone made a comment. If parents have rectified available in the business, and if you have to do more benzos, really conscious of the legislation that rectifies and so just about every common protocol that is consistent by the state. If you have hypoglycemia in a 2-year-old or any hypoglycemia, you can recommend the goal to get I just feel like I see that it's a good idea.